Over to you,
Good
Mike.
afternoon, everyone. This is Mike Andrews. I am the VP of Financial Transformation for Health Catalyst. That's a pretty fancy way of saying I'm an old cost accountant. Been doing cost accounting in hospitals and healthcare organizations for about 40 years, 38 years now. And so our topic today is definitely near and dear to my heart. With us to do the executive dialogue today is Rob DeMache. And Rob is the strategic advisor with Health Catalyst, and he is recently retired executive vice president and CFO for UPMC. And for those that don't know what UPMC stands for, it's University of Pittsburgh Medical Center, shockingly in Pittsburgh, Pennsylvania. And Rob will be leading our discussion today. There is a Q&A box for all of you that are on, and you can submit questions, and we will take some time throughout it if we need to and immediately answer the question. If not, we'll answer them toward the end. And also during the course of this presentation, we'll be stopping here and there for poll questions so we can get some idea and some feedback instantaneously from you on certain topics, and then Rob and I can respond appropriately to those answers. And with that, I will turn it over to Mr. DeMache. Thank you, Rob, for joining us.
Thanks, Mike, and welcome everybody. Thanks for joining. Let's just jump straight into the first couple of slides. I just want to start off with a basic, quick overview of Health Catalyst, what really the company's about. This slide just shows a footprint and some representative customers of Health Catalyst. Next. Some statistics on Health Catalyst at a glance. Next slide. And then finally, an overview of our products and services. And so if you had to summarize Health Catalyst, it enables customers to manage their data, derive analytical insights, to operate their organization and basically produce measurable clinical, measurable financial, and measurable operational improvements to what they do. And so on this slide, you see at the bottom, it is a data ecosystem. Above that is a layer of analytics applications, and they are both clinical, financial, operational, patient safety, population health. You see in the middle, top left, the Chorus solution for activity-based costing. And then also at the top, there's a services layer as well of experts in analytical, clinical, financial areas to help, if needed, with the implementation of these various solutions and technologies and data. So that's really Health Catalyst. Next slide. So my background, I didn't come from healthcare. I retired recently as the CFO of UPMC. I was the chief financial officer for 16 years. So I had 16 years in healthcare, but I actually had a longer period of time outside of healthcare. And that was in public accounting, primarily serving manufacturing and technology clients, and then with GE, which was primarily in a manufacturing environment. So one of the early questions that I had in comparing my early experiences in healthcare to my lifetime up to then experience in manufacturing was that, and I was actually at the locomotive division of General Electric, if you haven't guessed, was the rigor and focus on the manufacturing process, on variation. So the locomotive was highly engineered. Any change that was made, any change that was even suggested in the design or manufacture or servicing of that locomotive went through scientific engineering rigor. And I compared that to my early time, actually my entire time in healthcare, around that same concept was not applied. So it was more of a science in manufacturing, but in medicine, it was more of an art, with physicians practicing in different ways, significant variation, and not the rigor or science that I was used to from a manufacturing standpoint. So this really led to me asking questions, and our finance committee chair was the former CFO of United States Steel, was asking about what did things cost at UPMC? What was the cost of particular procedures? And where were we more or less profitable on different types of procedures, inpatient stays, et cetera? And I really didn't have an answer for him at the time. So we began the search of looking for solutions to this costing question in healthcare. And we came away highly unimpressed with the RVU methodologies and the ratio of cost to charges methodologies and the inherent inaccuracy of those other methodologies. And we went down a path of creating our own manufacturing-like activity-based costing system where we had detailed information and the ability to understand cost at a detailed level and at a patient level. And so that was really what led us to creating this new activity-based costing system, which is now Chorus. Next slide. So we can see now what's happening in healthcare. One of the reasons why cost accounting was not important is because we have been living in or had been living in a fee-for-service environment, which is basically a cost plus environment. The more you do, the more you get paid. And so in that kind of environment, revenue is king and cost becomes less important, if important at all, because really you're worried about volume and rates, and cost becomes sort of an afterthought or a byproduct. But two things have happened over time. There's been a move towards value. And this chart shows from left to right, moving from traditional fee-for-service, where there is no risk around cost, and there is no risk to the provider on performance, to the far right, which is fully capitated, where the payment is fixed, and now the amount of cost or effort or resource expenditure is how you derive profitability. And all of a sudden, as you move from left to right and risk comes into the picture, well, then all of a sudden cost becomes more important. But there's another dynamic which is happening right now, and that dynamic is COVID-19. That dynamic is the compression of revenue from COVID-19. So some systems have lost initially between 5 and 20% of revenue and volumes. That's come back now somewhat from the people that I talk to. It seems like most systems are back to between 95 and 98% of revenue. But that 2 or 5 or 3% of revenue, which has still not come back and may never come back, falls straight to the bottom line because primarily we have such a fixed cost environment. The other dynamic is the amount of competition that we have today. The insurers are now becoming providers, and they are now competing against traditional providers, and they're providing easy access, they're providing fixed pricing, and they're providing it in a way which is a direct competitor. They are steering people to their sites, to their own providers, and they're putting significant pressure on the traditional volumes that we've come to expect in a fee-for-service world. This is particularly dynamic in the Medicare environment. Medicare, older members, older patients, higher utilizers, that's who the insurers are focusing on. So they're looking at that Medicare population and they are steering them to lower cost sites. They are keeping them healthy to keep them out of the hospital. So there's significant pressure that is taking our focus away from revenue and placing it solely on cost and therefore the timeliness of this activity-based costing discussion. So with that, I think we have a poll question.
All right, let me get that pulled up. Okay, assuming everybody out there can see that, hopefully we'll see some votes coming in soon. This first poll question asks, on a scale of 1 to 4, how would you rate your organization's ability to accurately measure costs? And your options are 1, poor, 2, fair, 3, good, 4, excellent, and then you also have an option of unsure or not applicable, if again, you're unsure. If you joined us late, a reminder, we are going to have a Q&A with Rob at the end of this session today, so please do submit your questions as they come up and we'll try to get to as many as we can. Give you a few more seconds here to get your votes in. Appreciate you taking the time. All right, we're going to go ahead and close that poll and I'm going to share the results here. So it looks like 39% reported poor, 23% reported fair, 13% reported good, 6% reported excellent, and 19% just aren't sure. So I mean, you got more than 50% are in poor or fair. Rob, is that what you would have expected?
Yeah, this would be a quick webinar. If everybody said excellent, I would just say, well, look, you don't need any information from me or from Health Catalyst. So not surprising that folks, the industry in general, we know doesn't have great cost accounting. We know it's an area of emphasis that people are very curious about and looking for better solutions. So that poll Sarah seems to be consistent with where I thought it would turn out. So thanks everyone for participating. This next slide is a new slide that I've created, and I call it finance mythology around costing. And so if you recall, some of you from my generation that kind of grew up in the 60s and 70s and maybe early 80s, you might remember if you ever went swimming in the summer, if you ate lunch, you weren't allowed to go into the pool for 30 minutes. And I'm not sure why, no one ever explained why, but I just knew growing up that we literally were not allowed to go swimming for 30 minutes after we ate. Apparently it had something to do with the blood would go to your stomach and you'd pass out and drown in the pool. But that mythology was so strong and it was followed and it was never questioned. And it turns out, with the internet and with good medical advice, it's nonsense, right? There's no risk to swimming, but that was a mythology that we couldn't break through. We have similar, very strong mythologies around cost accounting in healthcare. And I hear these mythologies from clients that we talk to that are interested in a new approach. We hear it from ones that aren't interested in a new approach primarily. And I heard some of these actually at UPMC when we were creating the cost accounting system at UPMC. So the first finance mythology is we already do cost accounting and we already measure productivity. And the truth is you probably actually don't. And if you do it using estimates, you do it at a very high level. You probably don't do it on an individual physician basis. You don't probably do it on a service line basis. So these three myths that we're going to talk about, if you're a CFO, I want to challenge you on these myths and these traditional answers. If you're taking this back to your CFO, I want you to challenge them on these myths. I would argue that if you are using an RVU or an RCC methodology, you're not measuring things very well. You're not measuring them accurately. And so in my opinion, you're actually not measuring productivity effectively or efficiently. The second myth is that activity-based costing is way too complex, way too difficult to implement, way too difficult to maintain. And this is really counterintuitive. It is actually easier to maintain than traditional RVU or charge code costing because those involve updating RVUs, updating for new charge codes. Activity-based costing is driven by data that's in your EMR and in your clinical information system. So the data is already being utilized. It's already readily accessible. So totally counterintuitive, but it's actually easier to maintain while it is much more rich in data and opportunity. And then finally, the third myth is that we already do great financial analysis and we already have great operations support. And I'm not going to dispute you on that, but what I am going to tell you is that you can do so much more. You can do things so much better with this treasure trove of information that is available to you once you begin to combine operational data and financial data at a patient level. It is a whole new world. So this page, these three myths, I want you to help me to fight them and to understand that I violently oppose these mythologies because they're wrong and they're currently doing a disservice to our industry and holding us back. But I faced these same kind of myths at UPMC. I was told we're already doing these things. We already have a productivity measurement system. So some of this is counterintuitive perhaps, but this is the myth that needs to be dissolved before we can move our industry forward into the world that's facing us, the post-COVID world and the highly competitive world that we're in with the insurers. So I need your help in breaking down these myths. Next slide. Sorry, did we skip? Okay, here we go. I'm sorry. So there are the evolution of cost systems. We, again, as I mentioned, we started in a fee-for-service world. And so things were great. People were making tons of money and therefore cost wasn't important. And so things like RVU-based systems and RCC were fine. They gave some insight into the general profitability of the health systems, perhaps maybe by service line or perhaps by DRG. But activity-based costing, and this is a textbook definition, is a methodology to accurately measure activities, resources, and cost objects. Revenues and expense can then be determined at a patient level. So this is saying, and I'm going to talk later about why activity-based costing is the best approach. And we're going to debunk some of these myths in the following slides. So another poll question, Sarah, before we move on to the fun part.
All right, go ahead and launch the second poll here. Okay, in this question, we'd like to know which costing method do you currently use at your organization? And your options are 1, activity-based costing, 2, ratio of cost to charge, 3, relative value units, and then you also have the options of unsure or not applicable, and maybe you don't use cost accounting. You do have that as an option as well. So maybe they're just exploring a little bit more today with you, Rob. Okay, I'll give you just a few more moments to respond. Thank you to those of you that have already. Again, reminder to submit your questions as they become top of mind throughout the presentation, and Rob will tackle as many as he can during the time we have at the end of the session. Okay, I'm going to go ahead and close that poll and share the results. So interestingly, the majority here are actually unsure or it's not applicable, but 7% reported activity-based costing, which is our smallest group here, 20% reported ratio of cost to charge, 23% reported relative value units, and then 17% said they are not currently using cost accounting.
Yeah, so again, Sarah, pretty consistent with what we see in the industry. And I would tell you, and I promise to be provocative in this presentation and all the advertisements, and so I will. And I would argue that RCC accounting is not only inaccurate, but in most cases is blatantly wrong in the cost data that comes out, just because of the highly volatile nature of charge masters, their utilization within different hospitals within a consolidated health system. RVUs are big, large estimates that don't provide any physician variation. So again, this is the industry standard, but it also shows you the importance of us moving on to this next level. So with that, why don't we talk about the next slide and how is activity-based costing different? And again, this is another one of the important slides. Ben, next slide. There you go. Thank you. So why does it matter? And I want to spend some time drilling down on this, but healthcare today really separates accountability from the people that make decisions, and that's primarily physicians, and the actual record keeping or accounting or financial presentation of those decisions. So most places have a physician P&L and a hospital P&L, and never do the two meet. So as a result of that, the physicians are making decisions, and certainly they're making hiring decisions around which specialists and within their area, which physicians, which APPs they want to hire. And those are generally accounted for in a physician P&L. But at the same token, they are the ones that are placing orders at the hospital. They're the ones that are determining the supplies and the drugs to be utilized. They're the ones to determine the length of stay, the amount of imaging that's required. So they're making all sorts of decisions around resource utilization, but the P&Ls are completely separated. So there is no accountability. There is no linking of the activities and the costs. Instead, what we end up with are these very large pools of what I call indirect cost or overhead. And ultimately, what the current costing solutions do is allocate that back to procedures or to physicians on an average level or at a high level. And there's very little credibility with the physician because these are estimates and these are allocations. And so this disconnect creates a lack of accountability. And so the problem is, and I say Econ 101, for those of you that took an econ class in college, that doesn't make any sense because nothing is free. And for all of us, cost has a major impact on the consumption of a good or a service. So let's think of this as a consumer. when we go to buy something in the store or online, or we have a project for an addition to our house, we are always making value judgments around the cost of a service or a good and the efficacy of that good or that service. And we don't always want the cheapest available option. We may not always want the most expensive available option, but we want to understand those options. We want to understand the most costly option. We want to understand the less costly option. And we want to understand and make a judgment around the relative value that is inherent by making that judgment. And so this whole activity-based costing, it's really centered around the physician and empowering the physician. And let's face it, physicians are healthcare. They save lives, they break boundaries and barriers, they do amazing work. They are not the enemies of finance in this journey, far from it. In fact, they have been the best advocates for activity-based costing because they want to make value-based judgments and decisions. And the only way to do that is to understand the results of their decisions. So activity-based costing connects the decisions with cost. So if you go to the next slide, this is my decision. This isn't my definition. This isn't a textbook definition, but this is a definition that I came up with to try and explain this in a very simple way to people. So if you'll read along with me, activity-based costing connects actions and decisions of clinicians relating to the consumption of finite resources. Resources are not limitless, they are finite. To the actual cost of each action and decision. So let's do that one more time and let's cut out the middle. It connects actions and decisions of clinicians to the actual cost of each action and decision. So now there's an input and there's an output. And so our physicians now can make value-based decisions. There are implications of that decision-making on cost and quality. And no doubt about it, our physicians want to have the highest quality, but they are also engaged stewards of resources when they have the information and when they are accountable. So in the old model, physician P&L, hospital P&L, everything is free. The physician does not need to make a value decision because the actions of their decisions are absolutely free. Length of stay is free to a physician. The time in the OR is free to the physician. The number of images are free to the physician. The hiring of resources, and this was a great discussion we had with one of our potential clients. They used the example of their physicians requested that they put dietitians in a bunch of the primary care facilities. And so they contemplated that request. And they said, this makes sense. Let's go ahead and do that. They put a bunch of the dietitians in the primary care facilities. And it turns out in a couple of places, they were heavily used. And in other places, those dietitians were barely used at all. And those costs went into this sort of large pool of what they call ancillaries. And ancillaries, well, who owns that now? The hospital division or the hospital president. And the hospital president simply points and says, well, the physicians wanted this. So it's on my P&L, but they wanted it. So there's no connection. And what activity-based costing does is those physicians that thought that those dietitians were going to be a good investment to deliver better on the triple aim, better quality, better customer service, a better patient experience, they would back up that decision by being accountable for the cost of that dietitian in their service line. And believe it or not, our physician executives welcome that responsibility. They want to be connected to their decision-making. And activity-based costing and patient level and physician level costing is the only way to create that connectivity between decision-making and cost. So the takeaway on this is that actions have consequences. Actions have cost consequences. So to me, that is the layman's definition of activity-based costing and why it is needed in healthcare. Next slide. So this is the triple aim slide. So think of this as the nirvana for healthcare to get to the triple aim. And So activity-based costing, as I mentioned, the actions directly impact the health of the population. That's the quality aspect. They directly impact the cost. So how can you deliver on the triple aim of population health, lower cost, and a better patient experience if you are flying blind in terms of the decision-making and the impact that it has on the health and on the cost of delivering care? So activity-based costing in the Chorus system, it's not an event. It isn't an analysis that takes 6 months to do and is only good for a month or a quarter. It's systemic, it's repeatable, it's available immediately after the financial close, within 2 days usually. It identifies physician variation and practice variation. The physicians actually recognize their cost footprint. And we'll have a good example of that later, where many cost systems, you get sideways with physicians when you allocate large indirect costs to them. But when they recognize their cost profile, they embrace the activity-based costing. This is about consumption of resources, not allocating large numbers to various areas by spreading peanut butter, so to speak. And it's anchored. It's anchored to the general ledger. It's anchored to the clinical systems. And you're dealing with the total cost of these different areas. So there's one source of truth. The clinical EHR is the source of truth for clinical data, and the general ledger is the source of truth. So we're not dealing with hours or estimates. We're dealing with real data that is completely actionable. Next slide. This is a visualization of what we're talking about. So I like to think of this as a super collider, if you will. We're colliding clinical data from the EMR and from the ancillary systems with financial data. And it is so powerful when we bring these things together. We have all these subatomic particles of cost productivity, of the impact of consumption on cost, on physician variation. So this is, in essence, the commingling of clinical data and financial data at a patient level, which can only be done through activity-based costing. Next slide. So how does this all work? This works by assigning the general ledger data to individual patient activities. And we can do that because we know we have patient identifiers in the EMR. So we can find out the actual utilization of the direct costs. And by direct costs, I mean drugs, supplies, blood, and in some cases, labor cost when that's available. But we first apply the direct cost to the actual patient or physician on a specific basis. We take those costs out because we've already identified them, and I call those costs direct costs. But what we're left with in step 3 are what I call indirect costs, and we'll have an example of this in a minute. But these remaining costs, we want to assign them to patients. We do not want to allocate them. That's where we get in trouble. We want to assign them to the physician, to the patient, using the best available information from the EMR. And we have that information in the EMR. We know how long they were in the operating room. So we can assign that cost of their consumption of operating room minutes to that physician and that patient. We know how long they were on an MR machine. We know the length of stay. We have all this information. So we can assign the consumption of these resources to specific patients and specific physicians, no allocation. So that's a real high level of how activity-based costing works. Next slide. So this is an illustrative hospital P&L statement. So remember, I said the physician P&L statement is off to the side. So I just want to talk about the traditional P&L statement. So of course, we talked about revenue, and the old way of doing business was to worry about volume and rate. How do I increase volume? And how do I go back to my commercial payers and get more money? Well, guess what? Those days are coming to an end. The commercial payers, the businesses are struggling. They're looking to cut costs. The insurers are also competing against the providers. They're looking to reduce costs. So these days of 6 and 7 and 8% rate increases are gone. We're moving to government payers. We're trying to reduce utilization and consumption of healthcare services. So revenue is no longer an option. And with COVID-19, we know what's happened there as well. Some of those volumes will never come back. So then you want to look at direct, what I call service line costs. So these are things that are directly related to a patient that I talked about earlier: supplies, pharmacy, blood. Many RVU and RCC systems don't assign those directly. Some now do, and they're advertising themselves as activity-based costing systems. However, the problem is these types of costs are only at a max 50% of the total clinical costs. They're more like 30% of clinical costs. The majority of the cost of a hospital is in what we call these indirect cost areas, or these service centers that I call them, like the operating rooms, surgical services, like nursing, the inpatient stay, imaging, labs. So the majority of your expenses at a hospital are in these areas that we call indirect. So that's why it's critical to have a costing system that can properly assign the consumption of those service center resources to individual patients, to individual decisions and actions of those clinicians. What you're left with then are hospital controllable expenses. We never want to forget about admin expenses. I've had this experience myself at UPMC, and I've had other CFOs tell me, you know, we measure only hospital controllable margin and everybody looks great, but they forget about the revenue cycle and the supply chain department and the IT department. So all those admin costs, which actually support operations, that hospital margin actually needs to cover that overhead as well. Those are critical to operations. The revenue cycle is critical to revenue and collection. Supply chain is critical to delivering supplies. And so you actually have to get to operating income. So you've got to have a good sense around your hospital controllable margin, but also an understanding that overhead needs to be covered as well. Next slide. So this is another illustration of what I call the hospital mall. And the point of this is that 3 different patients getting the same thing done, a knee replacement, it could be an appendectomy, it could be neurosurgery. They're likely going to have 3 very different journeys through the health system. And that's based on physician preference. That's based on, next slide, how they enter the healthcare system. They may enter through the emergency room. They may enter through a physician referral, but everybody has a different journey through, or a different pathway through the hospital system. So very important in understanding you can't use averages, you can't use estimates or allocations, because every patient's journey, every physician practice journey is markedly different. Next slide. So the traditional view of reporting is from top to bottom. It's a vertical look. I'm concerned with the president of Hospital 1, and I'm worried about my revenue and my expenses, my salaries. So I'm only looking within the 4 walls of my hospital. Next slide. Unfortunately, most hospitals now are part of larger systems. Not all, but many. So the 4 walls of the hospital no longer matter. So this is the service line view of financial reporting. So if I am an orthopedic department, I'm going to have revenue, I'm going to have direct expenses, like I talked about, blood supplies, but I'm going to have all these service expenses. I'm going to be consuming imaging. I'm going to be consuming laboratory resources, surgical services, inpatient stay, nursing resources. So this is really a way to understand how individual service lines are performing. You could change the top of this schedule. Instead of having service lines, you could have Hospital 1, Hospital 2, Hospital 3 to see how they are performing, hospital versus hospital. You could have individual physicians' names up here, Physician 1, Physician 2, Physician 3, to understand how they're performing, a P&L, if you will, for each individual physician. So this is a new and more expansive way to look at things. Next slide. I talked about physician variation. So this is an example. There is significant variation from physician A to B to C to D around how they're utilizing supplies, their clinical pathways. You add quality onto this. What is the length of stay? What is the cost of quality? Physician variation is an area which not only can improve cost, but can significantly improve outcomes and quality. But we have no way to measure this, or this is a better way to measure this by using cost as really forensic evidence as to that physician variation. Next slide. So this is a great example that kind of pulls everything together here, which is the fact, and this is an example of a spinal fusion. And again, I want you to use this as an example with your own system or with your CFO, or if you are a CFO, how you would do this. But this is an example of one health system performed 852 spinal fusions. And the average cost in the bottom right was $18,220. But interesting, about only 50% of the cost, $9,950, was from direct expenses, and about 50%, 8,270, was from indirect expenses. So the time in the OR, the nursing resources from the length of stay, the imaging that was involved. And not only was, so the point is twofold. One is that, again, half of the cost is in the service centers, which we need to understand the consumption. But secondly, significant variation in physician practice here. So as you can see, for the 9,950 of direct costs on the left, there was actually variation that ranged anywhere from 45% of that to 162% of that. So somebody, although the average nut was 9,950, we had some physicians that were spending $16,119 on direct supply. So you could argue that, yes, there were some outliers and anomalies, but on 852 cases, that is a large enough N that the outliers can be put aside. So the point of this is you've got to understand your service center, your indirect costs. And secondly, you have to understand physician variation. It is a significant opportunity for cost reduction and clinical improvement. Next slide. So we talked about understanding ways to improve operating margins. So I wanted to go through what I call some tactical approaches, but then also some strategic approaches. So the tactical, many of them you may already be doing. Integration is great. We've all added additional hospitals over the years, but have we aggressively integrated everywhere? Have we implemented or integrated all the administrative costs, finance, HR, IT? Have we integrated patient access? Have we integrated scheduling? These are areas where there are still what I call outposts. And even if we've integrated the entity, sometimes we haven't centralized the function. And even after you've centralized, so you've centralized finance, it's under one leader in one area as opposed to being distributed out to every hospital. There can be issues where there's creep, where you start to see shadow organizations. So you want to go out and actually do what we call job mapping. We went out and profiled every FTE and their job title, and we started to see, instead of financial analyst, business analyst. And you started to see, instead of an IT analyst, some other job title which implied that they were doing IT-like work, program analyst. So it was interesting, even after integration and centralization, we were able to go back and find where these shadow organizations have started to grow and started to bloom out of what had been a successful integration. So those are areas where you can look to. Setting targets still works, across the board targets, whether it's 1%, 2%. That sort of shotgun approach to cost cutting still works, but there are diminishing returns been doing this. If you do it for year after year, so I've been in the cost cutting mode for about 12 of my 16 years at UPMC, there are definitely diminishing returns over time. So, but you can still, I think you want to have that as part of your cost cutting margin improvement set of tools that you're utilizing. Executive leadership consolidation over time, you'd be amazed at how many executives could come on board. So a simple test that I would do, and this is a great way to get people angry at you, is to take the executive's salary and divide it by the number of direct reports they have. And that highlights people that are so-called executives, but are not really directing any type of a large organization. And it leads to at least an opportunity to have a value judgment about their continued importance or the success of the organization and their part in it. Purchase services, looking vertically in the hospital, we'll talk about horizontal. And then the last are kind of revenue cycle. Physician referral leakage is always a good one to go after. Patient access, there is revenue that you're leaving on the table just because most systems cannot see patients on a timely basis with their specialists. Access continues to be an issue and an opportunity for healthcare. And the problem is, if we don't do something about this as a provider group, the insurers will take care of this for us. The telehealth providers and the insurers, the Oak Street Healths and the ChenMeds of the world will take care of this for us. And then just general revenue cycle improvements are ways to improve the bottom line. There's always a little bit of juice to squeeze, I think, out of revenue cycle improvements. Next slide, please. But there's more strategic cost reduction that can be done, but this requires advanced costing that you have through activity-based costing. So beginning to do service line management, what I call horizontal cost reduction, where you are looking, let's say that you're a health system of 5 hospitals or 10 hospitals or 50 hospitals, and let's say that you're around one geographic area. You're now going to start looking horizontally. where do I have programs? And what programs am I offering at each physical location, both inpatient and outpatient? It's interesting, by allowing physicians to have supply cost in their P&L, they now actually care about the cost of supplies. So I call it supply cost activation. When we moved to service line management and we allowed the physicians to take credit, if you will, for the supply savings that they could generate through standardization or through using lower cost supplies. Once they got physical credit on their cost cutting targets, we were able to realize a whole new tranche of savings and go from 5 vendors to 3 vendors, from 3 vendors to 1 vendor. It's a much different ball game when the physician gets financial credit for the supply savings, as opposed to when the old days, again, when you have a physician P&L and a hospital P&L, and the two shall never meet. Frankly, the physicians, other than being good corporate citizens, they have no financial motivation to even care about that supply cost savings. So this really energizes and activates supply cost savings. You will find new integration opportunities. The opportunity to not only close sites, so this is about consolidating sites, closing outpatient sites, physicians' offices that are underutilized, but also creating savings for strategic growth. Where, based on your population health and the population that you're trying to serve, where there are opportunities, where should you be adding sites, adding physician offices where you're not properly covering the geography of your catchment area, basically. So this isn't just about closure and consolidation. It is, but it's also about making sure that you have your locations in areas where there's opportunities for strategic growth. Purchase services horizontal. If you start looking across horizontally the health system, you can now start to do spend reduction by standardizing vendors. We found at UPMC that we had a different elevator maintenance contract and a different elevator maintenance provider for nearly every hospital, because we started to look horizontally. We were using different consultants for different purchase services. So we were able to start consolidating and realizing savings on a horizontal basis, because we can now look across the expanse of the system, as opposed to this vertical look just to down the P&L of a hospital president. So it opens up new areas. Physician APP integration. This is a tremendous opportunity to utilize APPs to the top of their license. So once physicians are responsible for their costs, not only their costs, but the cost of their APP, they are now incented to integrate to deliver better patient access and the highest level of care possible. So how do you fully utilize those APPs so that the physicians are at the top of their license and the APPs are the top of their license, and you're now creating more clinical opportunity, more clinical availability by fully utilizing them. And I call it a salary cap, just like in the NFL. How do you utilize the salary dollars you have available using world-class specialists along with APPs to see as many patients as possible, maximize revenue and volume, and at the same time do it at a value judgment around the total cost of care or the total cost of that physician APP expense. Clinical practice variation, that was the example that I showed you with the spinal fusion. It is a tremendous opportunity to improve quality and to actually lower your costs. But if it's invisible to your organization, there is no way for you to understand what the opportunity is. So you have to see it before you can act upon it. And then clinical productivity, what I call cost per target. So if you go to the next slide, we have a few more. I want to make sure we stay on time. But what is actually cost productivity? It's not available hours. This is an executive dashboard that we created. So again, utilizing the volume information from the EMR and the cost information for the general ledger. I now have 2 things that I'm measuring. I'm measuring the volume of a driver. And that volume could be, as you see below, med-surg days, it may be OR hours, it may be RVUs, and then the expenses related to them. So it's a naked measurement of cost and volume, input and output. The input is a cost, the output is a volume. And you're looking clearly and only to see, and you see the main drivers. The top is the total cost in the hospital, and the information below are actually the 5 largest drivers of those costs. So nursing cost, operating room, surgical services costs, drugs and supplies, those, and then actually provider physician costs measured against the volume driver. So I have expenses, I have volume, and then in the middle column, I have cost per. So in this example for nursing, volume went down 1%. My expenses went up 2% regardless. So my cost per med surge day is up 3%. So that's the only true productivity measure. It isn't nursing hours, available hours. We need to worry about turnover. We need to worry about nursing vacation. We need to worry about agency staffing when we're understaffed. Those all go into the total nursing salary amount so that I can measure my true productivity on cost. Next slide. This is just really a visualization of some of those slides. So again, you can drill this down. You can do it at a system level. You can do it individual hospitals to present them. On the top right, you can look at these individual measurements of productivity and show it specifically for surgical items, supplies, for drugs. Again, the same types of measurement by hospital. And again, you can do it at a top level executive dashboard and drill down all the way to an individual physician, an individual patient, an individual service line, an individual DRG. It's that level of flexibility and data richness. And then next slide, sort of the last two, and then we'll have time. I think we're close to being on time for about 10 minutes of questions. But basically, how do you win in the environment today? It's a strategic decision, but you have to develop a collaborative leadership model. You've got to work with physician engagement. Physicians lead this initiative around activity-based costing, believe it or not. So in the past, physicians were sort of the opponents of this kind of data. They questioned the data. And why wouldn't they? Because they would get an allocation from finance with some ridiculous amount of charge for length of stay. And they'd look at it and say, that's not my length of stay. Or they'd look at their OR hours and say, that's not my OR hours. So they didn't recognize their clinical footprint. And so you lost them right out of the gate. In this model, physicians actually drive the implementation because they believe in the data, they recognize their footprint. So again, you're creating credible patient level cost and quality data. It becomes really a prerequisite for cost productivity and service line management. To manage service lines, you need repeatable systemic data that's available immediately after your financial closing. And so that's really how you win in this new environment of compressed margins. So the last slide is the sales slide for you, which is to say that what's the value proposition? Of course, it's really the value proposition that I just went through with you. It is much better analytics. It connects consumption and cost. It allows your system and your clinicians to make value judgments around their clinical operations and their clinical pathways. It is easy to implement, or easier to implement and to maintain than existing and traditional systems. And it's actually very cost efficient. It can be done at the same cost or actually less cost than you're paying today for competitor systems. And I'll name them, whether it's an EPSI or a Strata or the bigger players in the market today. If you look at this value proposition, we have something that delivers better analytics that can be done and implemented and maintained easier, and it can be done on a cost-efficient basis. So those are my prepared remarks, and it looks like we still have 11 minutes, Mike, for any kind of a Q&A or other comments.
Yeah, Rob, let me start with a question. Right there in the
Mike,
middle.
Sorry, I was going to run that final poll question.
Yeah, let's do that. Let's do that first. Absolutely.
Make sure in case anybody needs to drop off. Sorry to interrupt you, Mike.
Sure.
All right. And Rob, we skipped over your third poll question. You were on a real roll. Did you still want to run with that, or?
Yeah, sure. Go ahead.
Okay, we'll do that really super quick, and then one other, and then I'll pass it over to Mike. Okay, so in this poll question, we'd just like to know, is accurate costing a priority for your organization? And your options are, it's a low priority, costing's not viewed as important, or RV or RCC has been deemed adequate. Option 2 is it's a medium priority, there are mixed views within the organization. Option 3 is it's a high priority, accurate costing is a strategic priority for your organization. And then lastly, there's an option for unsure or not applicable. And I'll just give you a few seconds there. We're going to make this one quick. I'm going to go ahead and close that and share the results. Looks like 9% said it's a low priority, 32% said medium priority, and 36% said high priority, with 23% reporting they were unsure or not applicable. Any comments on that one, Rob?
Well, so therein sort of lies the problem in that, the old solutions aren't going to serve us well in the new world. And I think I've made, and this again is through hundreds of discussions with physicians and operators about the information that they need to be successful. So how do we bridge over from what is needed now by our clinicians and then into the future to be successful, to get it to be top of mind for financial leaders that may still be following that mythology of, well, I'm already doing this, or it's good enough. So, it kind of shows, Sarah, the challenge that we still have ahead of us in terms of education.
Sure. Okay. And I'm going to go ahead and launch this final poll, and then Mike, go ahead and take it away for the Q&A. In this final poll, we would just like to know, after everything that Rob's presented today, essentially, if you'd like to learn more, would you like to receive follow-up from a Health Catalyst representative? If so, just let us know here. And I'll just leave that open for a few moments. Mike, you can go ahead and take things away with the Q&A.
Thanks. I'm going to ask you a question, not on the Q&A, but it's one that it's top of mind. Right there in the middle, you talked about ease of implementation and maintenance, Rob. Why don't you give us an example of your monthly close at UPMC, number of hospitals, how many people, and how long did it take to give us a proof statement on the upkeep part of this?
Sure. So I think I've lost count, but we're 40 hospitals, 400 outpatient locations, 90,000 employees. Our financial close, which was also very quick, we would do a 2 or 3 day financial close. So closing the books, the general ledger, and then the costing system, the costing information was available 2 days after that. So the ability to do service line financials, any type of cost productivity analytics 2 days after the financial close. So again, counterintuitive maybe to some who think, wow, this is very complicated, I've got to do all these updates. This is driven by the general ledger data. It's driven by the clinical EMR data, and it becomes really systemic. Once the pipelines are connected, it becomes very systemic to give results. So again, very quick turnaround, 2 to 3 days before that information is available for your teams to do in-depth analysis and supporting the clinicians and the operators. Okay,
Rob, we've got 3 questions out here, and I'm going to actually take the middle one first. That's how frequently, it kind of dovetails, how frequently do organizations traditionally update or upload their data into Chorus to have it timely? And you just mentioned it, within a couple of days after the month close, but you can actually look at year-to-date cost, and you could post daily or weekly during the middle of a month before your books close and have a pretty good weather vane estimate, but definitely a couple of days within the month close, you would have your data. It definitely monthly is the worst case scenario. I think.
Yeah, and and a lot of this, Mike, it's again, this happens automatically. So there's ability to update and upload data real time. And a lot of it is the ongoing maintenance. And again, not of the system. It's like, well, wait a minute, somebody added a new general ledger account, or somebody made a misposting to the wrong account. So what it also does, it actually helps with the accounting close, because it allows us to see where there have been sort of issues or misclassifications when things don't look quite right in the costing information. So it's a quick process. It's a systemic process. It can be done continuously, but it's more of a maintenance process. You can see where you have anomalies that can be improved and fixed to make sure that the pipes, you never want to have any leaks. And so you can see where there's any kind of activity by, again, either something in the EMR where somebody's not maintaining the hygiene of the EMR, or something's happened with your accounting systems. This becomes another tool that you can utilize to keep that hygiene on both the accounting side and the EMR side.
Okay, question here is, how do you use the EMR, or do you, to capture administrative costs, marketing, rev cycle management, salaries, et cetera?
So we use it to the extent that it's needed or necessary. So for what we'll do for marketing is we'll use primarily the general ledger there, because we want to understand the headcount marketing. We want to understand significantly is the purchase services. So it is any of the marketing material, materials, the television commercials, the sponsorships, those kinds of things. So, but what we do in revenue cycle, we want to make sure from an FTE standpoint, we're looking at cost per claim. And so we don't really need EMR data for that, other than to know the number of claims that have been processed. And then we want to do an extract from the salary expense to see our labor costs, how much volume are we generating? How many claims are we generating and posting based on that allocation, that finite allocation of labor resources that we have? So in this case, the real reason for using the EMR is because you want to have clinical volume data or clinical resource data. To the extent that you want to assess the marketing team, you might not really need the EMR data to do that. So if it's needed, it's there to utilize, but you don't want to use it if it actually doesn't contain any of the information. The good news is the Chorus system and the DOS system from Health Catalyst basically becomes a tool bench, a workbench. So everything is available in Chorus. So our FP&A teams use it as what I call FP&A in a box, because they don't need to go to other sources or databases to get operating information. The operating and financial information is all in one place.
A follow-up to that from the same person is, if you don't allocate administrative overhead, how do you assign these costs? Many physicians believe that these are big drivers of cost waste in the system, and you kind of touched around that.
Yeah, so for administrative costs, we don't want to get too caught up in, I don't know that I want the physician worrying about administrative costs, but I want our executives and our hospital presidents knowing, because the physician can't do anything about the revenue cycle, and the physician can't do anything about the HR costs. But so we want to assign accountability when somebody can actually affect change or change consumption or make a decision. So we want our physicians focusing on direct and indirect costs, and we want to hold our IT person responsible. Now, I will say this: we want to allocate the costs of the EMR to clinical operations. Maybe not important at a physician level, but certainly the hospitals and the physician division need to pay for Cerner or Epic or for an ancillary clinical system. The PeopleSoft system or the Oracle system that's doing payroll, that allocation I may not care as much about, because that's truly just an allocation. So this is all about assigning costs so that there's accountability to the people that can actually affect change.
All right, I think we've got time for one more, and I can actually take this. Asked, were the visuals presented today directly out of Chorus or a visualization tool? Obviously, these were PowerPoint slides, but as it says in the middle of the slide that our last slide, Chorus can be presented in Tableau, it can be presented in Click, it can be presented in Microsoft Power BI, it can be SQL Server reporting services. I will just say we work with the healthcare organization, and in many cases, they have multiple. They got a Tableau group and they got a Power BI group, and we'll just help them build the reports in both places so that they can use the tools they already have. We're not here to make you learn yet another report writer is probably the rest.
Well, so there's one more great question I want to answer. So to the answer to Alex's question is like, absolutely, it integrates. The visualization from Tableau or Power BI or Click is amazing, and it resonates with clinicians. So this data is highly, you can integrate it very easily with those visualization tools. So that's a quick answer to your question. Melissa, last question. Does Chorus have capability to support full decision support? So the revenue side, and can you use it as a decision support tool? So what I will say to you is that, and again, another mythology is that, wow, the most important part of what I do is around contract modeling. And I have this slick tool that can pull cost in, compare it to revenue, and give me an answer around profitability. The problem is the cost information's wrong. So even though you've got a slick interface and a tool that can utilize and compare contracts to cost, the costing information's wrong, your answer is wrong, and your negotiation is based on a false premise on the profitability of a certain service line or a procedure, because you're not really taking into effect the consumption of those indirect resources. So the most important thing is to understand your cost. And so, yes, we have tools, they're simple tools that can integrate decision support, But what I would tell you, the value proposition in contract modeling and decision support is around accurate revenue and accurate cost information, both of which you can get from Chorus. And the least important part of that is how you compare them in a spreadsheet or in an Access sort of database. So hopefully that answers your question.
For the remainder questions, since we do want to understand people's time, we'll follow up and get written questions back to you. We have y'all's email. Happy to do it. I know we're a couple of minutes over, so I wanted to thank Rob very, very much for talking to us today, and we will be happy to follow up for those people that want to follow up, and appreciate the over 60 of y'all that were on the call for the entire hour to listen to the good words that Rob had to say. If there's not anything else, we appreciate it.
Thank you.
Y'all take care.